Well, we're really pleased this morning to have three national CDFIs to talk with us about how social determinants of health is influencing their work, their approaches to measurement, and some insights they have on how community development and health can collaborate better to measure the impact of this great work that we're all doing. I wanted to give the panelists an opportunity to introduce themselves and tell you a little bit about their organization and what they do, and then we'll go ahead and dive into the discussion. Frank, do you want to start us out?
Sure. Thanks, Ela. Good morning. I'm Frank Altman. I'm President and CEO of Community Reinvestment Fund. We are a national community development financial institution headquartered in Minneapolis. Our mission is to improve the lives of disadvantaged people and strengthen distressed communities through innovative finance. And in doing so, we have financed about $1.6 billion in loans in 46 states and about 800 communities, primarily in low-income neighborhoods, focused on job creation, affordable housing, and community facilities.
Can someone just close the back doors there? Thanks, Mary.
Good morning. My name is Dave Kleiber. I'm a project consultant with Capital Link. Capital Link is a relatively small CDFI on the scale of CRF over here, but we work with the federally qualified health centers nationwide. So you all know the basic business model of FQHCs is they can't deny coverage or primary care services to anyone. In exchange, they get a federal grant and some Medicaid dollars. Capital Link has been instrumental in growing that network of nonprofits. There are over 1,200 independent nonprofits now, FQHCs like yourselves, that work under a similar business model, but all individual nonprofits. So we've been able to collect a lot of data over time from those entities, and now we're doing a lot of data analysis of this one subset of the healthcare world, which is primary care at the safety net level. So those results are kind of interesting. We'll talk about them in a little bit.
Hi, I'm Amy Gillman. I'm a National Program Director for LISC, Local Initiative Support Corporation, which is the largest national community development nonprofit in the country. And we raise investment capital and develop programs to support neighborhood revitalization in low-income communities. We're based in New York, and we operate in 30 cities through local offices, including here in the Twin Cities and also nearby Duluth. And we also have a large rural program that spans more than 1,000 counties in almost 40 states. And since 1980, we have invested almost $14 billion and leveraged another $41 billion from a variety of public and private sources to help develop hundreds of thousands of affordable homes and over 50 million square feet of commercial and community space in some of the most socioeconomically distressed communities in the country.
All right. Well, community development organizations play a very important role in addressing social determinants of health and creating health equity in communities. And I know that conversation is really starting to change in the community development sector and in the CDFI world. I know recently when I was at the OFN conference, there was a lot of discussion about health and equity and the impact that your organizations are having. I'm wondering if you can talk a little bit about how increased attention to social determinants of health has influenced your work and how you see your role in impacting community health. Amy, do you want to start us off?
Sure. I mean, I think certainly there's been a very dramatic change in the narrative around what contributes to health. And that has really given a lot of new energy and momentum to our community development work. And frankly, after listening to Alonzo's presentation, it's hard not to get very excited about what the future holds. But a few years ago, the vast majority of community development organizations had never heard of social determinants of health, and now it almost rolls off the tongue. And yet we know that health is connected to neighborhoods, not just individuals. And I think we've already heard today how our work to improve the quality of life in low-income neighborhoods really addresses many of the root causes of poor health. So our work really has always been all about health. We just didn't think of it that way until now. And I think what's more important is that it's not enough just to recognize this link between community development and health. we really need to act on it. And for LISC, that has meant a couple of things. One, moving away from a project-by-project approach, one-off transactions that might put a grocery store over here and an athletic field over there, and instead thinking about how everything fits together in a more integrated way for a community's health and wellness. And also, I think, broadening our traditional focus beyond the bricks and mortar and working to really connect the dots so that the physical assets we put in place are really well used. And that means having the appropriate programs and services in place so that residents really have access to a network of social and economic supports. And just a few quick examples of how that's played out for us in some different neighborhoods. In Philadelphia, we focus on the Eastern North community. It's one of our target neighborhoods, and we've invested there in hundreds of units of affordable housing, a new grocery store, a credit union. And recently, we invested in a large, multifaceted project called Paseo Verde, which is a transit-oriented development built on a former parking lot, has many of its housing units set aside for low to moderate income families. Some of them are supportive housing units with on-site case management, all designed with green and healthy practice, and has a commercial component that has a new federally qualified health center, a dental clinic, a pharmacy, and a LISC Financial Opportunity Center that assists residents with employment and personal finances. And we're not stopping at the physical infrastructure. We're also bringing together the housing manager with the health provider to help increase access to health-related services and supports for residents, both at the clinic, but also through things like home visiting in the actual housing units. And right here in Twin Cities, we've taken it even further. We have a community health advocate on the ground, a local staff person whose job it is to actually think about how do we incorporate a health agenda into our ongoing community development work. And here we're focused on the east side of St. Paul. It's part of a national pilot in 4 neighborhoods around the country. And that's a neighborhood where we invested in the expansion of a new federally qualified health center, and nearby brought our Healthy Futures Fund resources to renovate an affordable housing development, and even brought extra funds to equip an exam room right in the housing, and now are bringing together the housing and healthcare side to think about how to reach the immigrant and refugee population of the housing so that they have access to culturally appropriate care, physical engagement, and access to healthy food.
Dave, how do you see the conversation changing in the community health sphere that you work in?
Well, that's a good question, because health centers really do, they are animals of how they are paid, right? Most of us are on some level. And I think this is a great example. I mean, that is the social determinants of health on an operational basis. But most health centers, though they can say the words, will tell you on some level, when it gets down to it, it's not my job. Right? Because my job is to, at the moment, the way the payment system is set up, is to see more patients, because I get paid by the visit, not for the overall health of the individual. And so I think that this is encouraging, but from a national basis, health centers are not necessarily embracing the social determinants of health on an operational basis, because the housing is new to them. You know, criminal justice, education, all of that is new to them. They see themselves compartmentalized, and we're going to have to change the way they're paid if we're going to change their incentives.
Frank, how are social determinants of health influencing CRF's work at this time?
Well, I think that we've always looked at what we do through the lens of economic opportunity. And opportunity, the theory of change that we have is that if you give people an opportunity for a better life economically, these other things will come into place. I think in the recent years, we've begun to think about things in a slightly different way and talk about the ecosystem that is necessary for a community to be healthy. And there we're talking about not just the people, but the institutions that operate within neighborhoods and communities. So having good schools, having access to health care, having decent, safe, and affordable housing are all components of the ecosystem. And most importantly, having the opportunity for a well-paying job that has a living wage and hopefully an opportunity for advancement are all essential components to a healthy community. And so as we look at our financing activities, we've been looking at through the lens of this ecosystem, which I believe is running parallel to the social determinants of health, or creating a culture of health. And I'm really looking forward to further refining that as we evaluate the transactions that we're going to do, the partnerships that we have with community development organizations around the country.
We're talking about data and measuring impact today, and I know that many CDFIs and other community development organizations regularly use data to target their program investments and demonstrate the impact of their work. I'm wondering if you could talk a little bit more about how data on community conditions is used in your work, and then also how you are taking steps toward measuring your impact on community health. Amy, do you want to start us out?
Sure. We're certainly trying to move from thinking about outputs to thinking about outcomes. But LISC, like so many community development organizations, we're comfortable counting things: square feet, dollars in, units, slots. It makes us happy. But as we have become much more neighborhood focused and much more comprehensive in our scope, we're really trying to think about how to get to the impact of our work on the people who live in the communities that we target. And so one thing we're doing in the big picture is our research team is carrying out an ongoing study of the impact of our investments in a place, based on the theory that it's a strategic infusion of investment in a neighborhood that really makes a difference. And so basically we're trying to answer the question of, are our target neighborhoods better or worse off since we got there? And so they're looking at the neighborhoods where we've had the highest level of LISC investment and comparing them to neighborhoods where we're not present, and seeing whether we are moving the dial on things like poverty, median income, employment. And what we're finding is that it seems that LISC investments at the neighborhood level are correlating with lower poverty, higher income, and more employment compared to places where we're not. And these are early results, but promising and I think significant for us as we try to figure out how our work to improve the quality of life overall really has an impact on the people who live in that place. But as we're getting more intentional about our approach to health, we also want to build into our work and into our evaluation how our work has a specific impact on people's health. And an example of that is in New York City, where we just launched a new program called Communities for Healthy Food NYC, which is basically an effort to integrate healthy food access into every level of community development work that's happening in 4 target neighborhoods. And the idea is that we are drawing on the existing assets of our local community development partners who have been in those neighborhoods for a long time, have built and own and manage affordable housing, have close ties with the residents, and who are providing a wide array of other social and economic supports in those communities. And now we've placed community healthy food advocates on the ground, modeled after our community health advocates, and they're implementing a set of strategies to infuse the community development approach at every level. So everything from nutrition education for residents to training of building staff in gardening and food preparation, bringing healthy food into early childhood centers and schools, linking small business and economic development programs with food-related jobs, and also trying to create new food venues in vacant or underutilized commercial space that they also manage or control. And we've engaged the New York City Food Policy Center to do this evaluation, and they are looking at the overall approach of infusing community development with healthy food access at all these levels. And it's different for us this time because we are using new tools that include resident focus groups and surveys, and also observations of the food environments in these neighborhoods, also have some comparison neighborhoods, and observations of different activities and events that are going on through this initiative. And what we're hoping is that this will give us a good before and after look of changes in perceptions, knowledge, and behavior as it relates to healthy food. Do people know more about what's available? Is there more available? Are people actually buying and preparing and consuming healthier food? Are the programs and services that were there better coordinated? So now I have to say this is an evaluation that has just started. We're in the baseline data stage, so I think you're going to have to invite me back next year so that I can tell you what happened.
Well, Amy, I know that you mentioned earlier that we like to count things. It makes us happy. And starting to get a better understanding of the types of systems that are in place for community development to measure impact. Frank, I'm wondering if you could tell us a little bit about what CRF currently uses as you think about targeting program investments.
So when Ela invited me to be on this panel, I thought, well, how am I going to talk about? Because we don't really gather any health indicators as part of our metrics. And then I thought further, and I said, well, no, we're looking at a lot of information. We just maybe don't look at it again through this lens of healthy communities. We're looking at it through the lens of economic opportunity. So I look at the data that we gather and how we try to see if our theory of change is working, both in terms of data we gather on transactions that we do, but also the information that we gather on the locus of the transactions. And to the extent that we are part of a community development effort that engages other partners, we try to look at, well, what is the collective impact of our efforts? So on the health side, some of the things that we start off with is really trying to understand what is the economic environment in which a particular transaction is being financed. And so we use census data to inform us about unemployment rates, crime rates, certain other information that is essential to our understanding of the neighborhood that a particular project is going to be located in. And we have used, for the last several years, a data source called Policy Map. Policy Map was developed by one of our sister CDFIs, the Reinvestment Fund out of Philadelphia. And it really is a remarkable tool for looking at a whole variety of indicators around particular types of transactions that we get involved in. So if we're looking at a business loan transaction, we get information on unemployment and certain other activities. But if we're looking at a charter school, which is another part of the ecosystem I talked about earlier, we'd be looking at educational attainment rates and other things related to that community. So we start off by trying to understand the environment in which we're operating. And then when we're doing affordable housing and increasingly other commercial investment, we're looking for LEED buildings. And LEED is an indicator both of sort of global climate improvement, hopefully, fewer emissions, but also these are going to be healthier buildings. They're going to be buildings that maybe are pushing back against what's been happening in a lot of communities in terms of asthma and other things that come from building materials and so forth. So those, I think, would be examples of the kinds of things that we're looking at. But I think our whole industry has a long way to go to integrate the data that we were hearing about from the earlier presentation and how we can really change the health outcomes.
As we were getting ready for this call, Dave shared with us some two key data points that I know that you have in your folders. It should be the last handout on the left side of the folder. But Dave, can you tell us more about these numbers and how they factor into how you think about measuring impact?
First of all, it's really interesting because the community health center world is effectively a single-payer system on a micro scale, right? It's like a small experiment in the single-payer system, and because of that, it has a government overseer, the Health Resources and Service Administration. So they mandate that every federally qualified health center generate the kind of data, a lot more than this, but this is where this data came from. So you're looking at a graph right here. It's called How Effective Are FQHCs? And when I'm in a health center conference, I use it as a gentle nudge because you'll see that the numbers here are there are two different trends. One, the bar you'll see is rising over time, just since 2008. That's the overall cost per patient per year at health centers nationally. But when you look at how effective they are, in other words, how good are they at controlling chronic diseases and reducing the impact of chronic diseases, those lines, for the most part, are flat. And in this conference, I'm going to use this as a kind of evidence that there are effectively more than that healthcare is more than the intervention and the illness-based approach that Dr. Plow talked about. It really there must be factors beyond that visit, beyond the doctor's ability to just treat asthma, to treat chronic high blood pressure, to treat diabetes, right? Because no matter how much money it looks like we're spending more and more and more, there's not been a great movement in that number. So that's where this group and those who can control the other social determinants really play a role. So it is interesting in that this is an industry that does generate data. I remember when I was a general lender, like what Frank does and what LISC does on some level, being across industries, I would have sold my soul for the kind of industry-wide comparative data that the health center industry has through this uniform data system. So if you're ever working with one of those, you can really tell a lot about that. But it's a small fraction of the healthcare industry as a whole. Can you get the same information from private practice physicians? No. Can you get the same information about hospitals? Not to the depth we can here, right? So what's the future if we don't have that information coming? The other thing I'll talk about a little bit is electronic health records, right? You probably have read in the news. The big transformation for health providers is they no longer keep a nice folder like this with your name on it. Well, some do, but for the most part, it's on computers, and it's been a multi-billion dollar effort to get this done. And now the latest news is, hey, guess what? They don't talk to each other. So I've got a good electronic health record system, and you have a great electronic health record system. But if I go to your shop, you don't know what my records are because we're not talking to each other. Again, that's probably the result of HIPAA, the privacy mandate that we have as a society, that our health records are our own and nobody else's. So you better create a lot of barriers to protect those health records. Well, how do we do population health if I, as a hospital, can't get your records from the primary care provider down the street? So we have some societal changes. We can generate all the data we want. If we can't get to it, it's not all that useful. So there's kind of some of a little 30,000 foot view of how data is useful and is being generated, but may not be as useful as it could possibly be.
Before we can talk about solutions, I do think it's really important for us to understand very clearly what some of the challenges are that prevent community development organizations and their partners from regularly measuring the impacts of their projects. And Dave, I'm wondering if you could maybe start us out, since I know you sort of ventured into talking about some of the challenges. Can you tell us more?
Sure. I mean, I don't represent the entire healthcare world. I represent the FQHC world. But 95% of their patients are underneath 200% of the poverty level. And if you know how that was generated and what number that is, that's not much money. So we are talking about the very low income population. A couple of quick concepts, and some of which you've heard of. Hotspotters, right? Overall, the emphasis in this country is to reduce the overall spending on healthcare. If you look at any graph nationally, we spend about $8,400 a year on individuals' healthcare, where the next developed country down spends about half that, while our results are at the 25th level, best impacted, best results health-wise compared to the rest of the developed world. We have to bring the cost curve down. So how do we do that? Well, there is this concept of hotspotters, which is, at least in the Medicaid world, it's the old 80-20 adage. About 20% of, well, actually even less, of Medicaid recipients are responsible for over 80% of Medicaid spending. And that's because they have multiple comorbid conditions. It sounds so horrible. But basically, they've got physical health issues, they have mental health issues, they have substance abuse issues. And beyond that, they probably have housing issues, they probably have interventions with the criminal justice system, they have education problems. I mean, their whole world is really is expensive for society to maintain and to control. So, when you're got a healthcare system that's being driven by the visit and not by taking care of this individual as an entity, as a person and as a whole, and control their costs, that's what happens. So speaking of pilot projects, the flip side of that paper I sent out is just one example. I won't go through it, but it's one example of work done in Boston. that just said, let's identify some of these folks. Let's bring the resources together to deal with their problems holistically, right? And not as individual siloed providers of care, housing separate from healthcare, separate from substance abuse, separate from mental health. Can we generate savings? And if by just going through here, you can see, well, yes, and it could be fairly dramatic. And if you ramped it up, it would be really dramatic. But this requires a fundamental change in the healthcare system as a whole and how it's paid for, how it's managed, how the incentives are set up, right? And that's what I think is one of the biggest roadblocks to moving us forward along this. I mean, no one will argue that the social determinants of health aren't kind of like a duh, that makes sense, right? It's just so obvious that your housing and your healthcare and your education are all tied together. But how do we actually implement it on a national basis? And that's where, it'd be interesting to chat a little bit with Dr. Plow, because some of what you guys are trying to do is great. But for instance, you talked about, entities having the capacity to do certain things as opposed to being incented to do those things, right? People are creatures of incentive. So, I would love to see that the system was set up for people to actually say, hey, if I pursue working with the LISCs of the world and the CRFs of the world to meet those social determinants of health, that I actually get rewarded for that, right? And there are ways to do that under payment systems that are evolving, these ACOs, accountable care organizations. But we're a ways from that. But hopefully that's a hopeful, goal we have to get to eventually.
Amy, could you talk a little bit about the challenges that you've come across in measuring the impact of LISC projects and working with some of the partners you've worked with?
Sure. A couple of things that I think make it a little more difficult sometimes to capture the value of the community development role. One is that, our work is premised on the notion that you have to tackle all of the social determinants of health, or the physical, economic, and social factors at once to really improve a neighborhood. So it's housing, education, safety, transit, and all the basic needs that have to be addressed simultaneously, because you don't want to have progress in one area and have neglect in another really undermine that. And so I think we all know that that's probably especially true when it comes to health and improving health outcomes. And so one issue really is when you have multifaceted efforts like that and you have multiple partners, not to mention which there's so much already going on in these communities all the time, how do you really pull out, which investment, whose role, which organization really is what you want to focus on and invest in moving forward. And I think, another take on that is that one of the most important roles a community development organization like LISC can play is as a catalyst. We're often the first investor in a project that might be risky or marginal, and that's what gives others the confidence to step in and invest as well, hopefully in a bigger and longer term way. We also often play the role of broker and facilitator. We bring partners together. We help form or guide a coalition. We think of strategies to engage residents. And our success is often when those things have happened and we're not needed. So capacity is built, partners are formed, other money comes in. And so how do you put a value on that critical early catalytic role?
So I told the panelists that I wanted to make sure that we maintain the level of optimism about what we could be successful at and what we could do together. And Frank, I'm wondering if you could talk a little bit about what you see as opportunities for the future in terms of us measuring things together. What types of relationships need to be built, data sharing. You have thoughts?
Sure. The first thing is there's a whole bunch of people in this room who are really expert in public health and public health indicators and statistics, and I would say the community development world knows very little about what those data are. And so to the extent that we can start sharing back and forth among our two industries or multiple industries that are represented in the room, I think that would be very, very helpful. I know in examples of things that have come to mind that I think would be fun to look at. I know there's a walkability index, and as we're looking at one of the social determinants of health is exercise and fitness. Do we look at things like that? Can we look at things like that when we're looking at an affordable housing development? Is it in a place that's near a sidewalk? I mean, these are kind of strange questions because you'd say, well, sure, but in many cases, nobody's looking at that. So that's an example. We try to look at data on the performance of charter schools. We finance a number of charter schools, and we want to be financing schools that are making a difference for students. So you have to go outside of our own metrics to the metrics of the others, and it begins to be quite an effort to collect and be able to then tell the story. As I indicated earlier, we look at wages, very important indicator, I think, of economic opportunity. But there are bigger issues, and I don't see them here. I saw them on the list, but one of my board members, Mike Christensen, served as the head of the community planning and development for the city of Minneapolis a number of years ago. And during that period of time, a number of us, LISC included, neighborhood development organizations, worked collaboratively to really invest extensively in the Phillips neighborhood in South Minneapolis along Lake Street and Franklin Avenue. And we were able to gather data over time that really showed, and we meaning this whole group, that really showed the outcome of that investment. And that outcome was a dramatic reduction in crime and a dramatic increase in development and tax base and living wage jobs. Resulting in major development and opportunities for minority business owners, the Midtown Global Marketplace, and a variety of other things that came out of that sustained collective effort. Did we look at that through the lens of health indicators? No, but I think if you look backwards, driving crime rates down, driving job opportunities up, we have addressed those social determinants of health. So how do we gather the kind of information and the indicators that you're all aware of going into the future that strengthens our case and makes it possible for us to see if we're moving the needle? And I think that opportunity is there. I want to say one other thing, and that is we have to remember that what we're doing is not all numbers and statistics. There are stories behind everything that is done in community development. And so I look at an example in this neighborhood that we were talking about, called Phillips Gardens. That was something we financed several years ago. It was an abandoned gas station with a little area where you could drive underneath an overhang, and that gas station became a locus in the community for drug deals. And by driving by repurposing that building into a functional business, we had a tremendous impact on health indicators, but we didn't know that. We were trying to get jobs created, but we also helped to drive out a site where there was a lot of illicit drug activity going on, needles and so forth. So it's important to understand the stories behind the metrics and statistics that we're all trying to measure.
Dave, Amy, do you have a key piece of advice or opportunity that you see?
I guess an opportunity. We always talk about how data is a challenge, but I think data is an opportunity as well. And I think, Dave alluded to both the challenge and opportunity of it. But I think there's just a tremendous opportunity to marry community development's ability to structure really creative and sound investments in health in communities with the health sector's ability to measure actual health outcomes. And, we're not there yet at all, but I think we're starting to see through our newer partnerships with both healthcare and public health in some of our sites that there's really a lot of potential for both collaboration and data sharing. And a good example is in another one of our community health advocate sites in mid-north Indianapolis, where we were really challenged during the needs assessment process because we just didn't have any neighborhood-specific data on health. And it wasn't that the community didn't know what they were struggling with. There was certainly lots of anecdotal information, and the residents themselves who were involved in the process certainly knew what health inequities there were for them in that place. But the tipping point really came when IU Health, which is the largest healthcare system in the state, came to the table, literally taking a seat at the table with the community, joining the community visioning process, and provided to us for the first time zip code level health data. And that was what was really needed to motivate and drive the process and guide everyone to coming up with strategies to address those needs. And I should also add that IU Health also funded part of the Community Health Advocate program, which gave a huge boost in credibility, because it's one thing to say, oh yes, we have health partners, oh yes, they came to a meeting, but here was a very important health partner who literally sat at the table and gave very hard to get information and dollars to help us strategize about how to create health in neighborhoods, not just in their hospitals and doctors' offices.
Well, and I'd hate to have you walk away and think, gee, that Capital Link guy sure was a negative Ned. You know, you have in your own community an example here, North Point Health and Wellness, just northwest of the city here, who's embarking on a project that's really quite creative and important in the sense of bringing nonprofit activities in employment and mental health together with their primary care provision as at FQHC. And they're going to be embarking on a whole new project up there, which is transit-oriented. It's going to be great. I mean, that's the direction we need to go to. FQHCs are getting that, going down that road, and they can use your help as community partners. But there are examples out there of us getting incrementally down the road.
And can I also just add one extra thought, which is, you know, we as community developers, you know, we know what we do. We improve neighborhood environments so that it makes it easier and more affordable for people to make healthy choices. And we also are quick to say that we can't tie our work to a change in actual levels of chronic disease. But I do also think there are some exceptions to that, and asthma is one of them. And the project I mentioned in Philadelphia that was designed to the highest level of green and healthy standards, so it was really taking away the toxins, dampness, mold, better ventilation, smoke-free units. And the housing manager that operates those units said that almost immediately from the time that new families moved into those units, they were reporting much fewer issues with asthma, particularly in their children. And I think that as we work more directly with health partners, we can move from the anecdotal, which I agree with Frank, the stories matter, so I mean that mattered to us, but we, I think, can become more systematic when we can actually track actual health outcomes, you know, reduce number of visits to the emergency room, and other ways to quantify the results that we know we're getting.
We have about 10 minutes or so before we break for lunch, and I know that we have a wealth of expertise in the room, number of health experts and evaluation and research experts. And I'm wondering, what questions would you like to ask the community development industry in terms of how it might impact your work? Panelists, do you have questions that you'd like to ask the health and evaluation experts in the room?
We solved everything.
Everyone's so quiet.
I just want to say, we actually finance bowling alleys, so people don't have to bowl alone. We've also done fitness centers. They're very, very risky, but so.
Looks like we have a
question. Well, I have a question here. I wanted to respond to what Dave was talking about as far as the e-health records and the need to collaborate between systems. I was looking at parts of it as it was going through the different segments here in Minnesota, and what they found was that it was the equipment that was unable to talk to each other. And so there was a point where, for example, I think Microsoft, Apple, Dell, their systems didn't talk to each other for a while until it was regulated that they ought to come up with compatible systems. And I'm wondering to what extent you can influence that so it happens, because they spent a lot on essentially equipment that's now useless, and they have to buy new equipment is one thing. And then also expanding on that is the business sector who in the healthcare field, because I also deal with those in medical devices and so forth. And they basically said, well, we pay a lot of money for our research and development. We need a way to recoup it back. We can afford to sell it for less and do our services for less, but we aren't going to do it because we need the money. So how would you respond to those?
Well, it's interesting. I'm sure you guys run into this in each of your own individual worlds. But if you go to an FQHC conference, right, you get out and there's an exhibit room, which is what pays for the conference, and 3/4 of the tables are EHR providers, right, electronic health record providers. Each one wrote their own code, wrote their own system, and by God, has the best system out there, absolutely. Unfortunately, it doesn't talk to that guy's system over there, right? You need interfaces, you have to spend more money on the software and the hardware. So what happens over time is they're going to acquire each other. It's happening now. This is just the way America works, right? It's great. It's the entrepreneurial way we are. But had it started out with one standard for this is the kind of code you have to write in so that we all can talk to each other, we might have a different result. But that's just part of our DNA, that this is how we move things forward. So we have a time period we have to go through to get all the systems to kind of consolidate and start talking to each other. It's not an unfixable problem. It's just unfortunate that we have to wade through this while we're waiting to get to the home run of systems that help. That if you go on vacation and fall and trip and break your hip, you can go to the hospital and they'll know all about you. It doesn't happen right now, right? So,
In the back?
First of all, I want to say that I'm very impressed sincerely with the quality of work that's gone on at the community level in this kind of effort. My concern only is this, that without policy change, what we may be doing is helping it get worse more slowly. Because what's happening in the larger society, those trends and those policies are so hostile to healthy development. My question is, if you could recommend policy changes and pick any sector you want, what are the most important policy changes you would see?
You all look like you have something to say. Who wants to start?
I look at this. So I thought it was really interesting that there's all this money being spent on blood pressure as an indicator. Blood pressure, I don't know if it's being spent on blood pressure, but the outcome is not changing when you look at this line. And being somebody who is personally afflicted with chronic hypertension, I just am amazed at the amount of salt that is put into food. Right? So is there a policy change there? I mean, this is looking at things from a different perspective than community development, but are we, when we talk about healthy foods and we have industries that basically sell salt, sugar, and fat, and then we wonder why we're having a problem with chronic illness, there's an opportunity, it seems to me. So how does that relate to community development? Well, we are heavily involved right now in the food charter that you heard about earlier and trying to come up with healthy food options. But recognizing that our society is developed on convenience and what can you put in the microwave and so forth. And so how do we get behind entrepreneurs who want to change that? CRF has financed a number of food producers. I think they're in the healthier food segment of the marketplace. But I think there's an opportunity for proactive work on the financing of these activities and to a certain extent, regulation that helps to remove some of the things that are systematically causing some of the problems that we're seeing. And we're hearing about it with high sugar in schools. I mean, there's a lot of effort going in this direction, but those are areas of policy that I don't know if I'm getting outside of the community development world, but certainly, I look at this and what a sad thing it is to see that line hasn't changed a bit. So.
go ahead.
What I would really like to see is a way to have more health dollars pay for health. And, the community development field has been investing a lot of money in things that directly and indirectly relate to health. But I think, frankly, the industry is just not big enough to address all of the needs in every neighborhood all across the country. And so I would like to figure out a way to see how some of the substantial resources that are going into medical reimbursements are spent more on community-based solutions. And we're starting to see a little bit of that, not from policy change, so I'm kind of only half answering your question, but saying what I want to say. We're seeing some of our initiatives and programs, particularly around healthy housing, being paid for now through public health departments. We have a close relationship in New York City with the District Public Health Office, and they fund a program we run called 2 Shades of Green that introduces smoke-free housing and pest control and different interventions in existing housing units. And so that's one way we're seeing, sort of health money being directed into health in communities. So that is sort of a big wish list kind of policy change, but to me it's the most important one that we can wish for.
And I'll dovetail on that because you're right. There's enough money in healthcare to pay for a lot of this social determinants of health. At $8,000 a person, we're spending a lot of money on people's health with very little in the, well, not little. We have a good system. It's just not as good as it could be. So what policy change would I make? Well, this will come as a huge shock, I'm sure, after hearing me. But and this is not a Capital Link view, but eventually we're going to get to a single payer system. I know that's anathema to probably half the room, but the only way you can, and in the meantime, we're going to get to this ACO concept where it's back to managed care. I'm paid to manage your health, not to fix you or to see you for 15 minutes. And it's even better if it's a 10-minute, because then my productivity goes up and I get paid more, right? That's the system now. It's that, gee, Mrs. Jones, let's talk about your substance abuse problems. Let's talk about the fights you have at home with your kids. Let's all the stressors, the mental health issues. I'm gonna really take care of all your health. That's how, when we can do that systematically, we'll reduce the costs of care at the primary care level. Here's, not to go on and on and on, but the bugaboo with that is that some money's got to come out of the system, right? And the money's going to come out at the hospital system. That's the hospital level. Well, guess who's got most of the weight in the system? Hospitals, right? That's where all the money's invested. So they're not anxious to see money that goes to them leak out to primary care, but that's almost absolutely essential if we're going to increase the people's health and lower overall cost, because a primary care visit's $125, and a visit to the hospital, as anybody here who knows is rarely below 4 figures, right? So that's kind of the rub. But if I could wave my wand and create a policy change, not Capital Link. Dave Kleiber would bring in a single payer system.
We have time for one last quick question, and I'll leave it up to our roaming mic people to decide who that is.
All right. So John Moon with the Federal Reserve of San Francisco. So the community development sector is really very good at and adept at repurposing capital and reshaping it toward new emerging areas like childcare centers and fresh foods and charter school finance. In health, what are the barriers that you see in terms of deploying capital, and what changes would be needed in order to expand the investable opportunities in health?
It's a broad question. Are you talking about health facilities or?
Broader social determinants of health. What we do, I mean, because we've done fresh foods, we've done clinic finance, but the broader social determinants. What can be done to start paving the way for the other areas? Whether it's the challenge of long-term capital, or the fact that it's more human capital oriented, or reorienting to new repayment sources. Those kind of challenges.
I mean, I think there are a few things. One, there are a lot of things that you can't pay for with debt because it's not going to get repaid. So there's a lot of activity now in the community development sector that is contributing to addressing the social determinants of health that are not necessarily going to produce a return on investment. So we need more flexible grant money for programs and operations and things like measurement. And that's very hard to come by. And I think there's also a sense that in the community development world, everything can be a transaction, and that you make money off your transactions, and that kind of feeds your activity, which I think is true only to a certain extent. Well, I don't know if somebody else wants to jump in and say anything else.
I think that there are, the way I look at this is that you have to look at very significantly precise segments and say, well, where can the capital be used to grow activities in segments within the larger community development world. So we talked about some of the big segments are education facilities, daycare or early childhood, healthcare, affordable housing, jobs and business finance. community facilities, boys and girls clubs. I mean, it's a whole range of things that are in that world. And then how do you exploit those segments in a way that they can be financed effectively? There's a big challenge, I think, in the changing healthcare system, and a big opportunity. And I just, for those of you who are not in the banking and finance world, we have something in banking called the Community Reinvestment Act. My understanding is, with the Affordable Care Act, over time, hospitals are going to be looking at their populations in a very similar way, although not as banks do, but in terms of outcomes in the populations that they draw a map and say, we're going to serve this population. There's an opportunity there, I think, to take that approach and use what we've learned in the community development world over many years with the Community Reinvestment Act to enable hospitals to have outcomes in partnership with community development organizations that I don't think any of us really would have been thinking about 3 or 4 years ago. So there I think is the opportunity for repurposing capital.
Well, I do see some more hands in the audience, but we are at time, and I do want to keep us on time. So Amy, Dave, and Frank will all be available. I encourage you to reach out to them with your questions during lunch. Please give me a hand in thanking our panelists.